Okay, we ready
Hi
to
there.
go?
Good evening, everybody. Welcome to this evening's webinar from Veterinary Instrumentation. I can see our numbers going up. I'm just keeping an eye on the numbers in the bottom of the screen. Looks like we've got lots of people logging in, which is great. Hello and good evening to everyone who's just joining. I can see the numbers still going up. Victoria's asking, will this be recorded if we need to leave? Yes, the whole session's being recorded, so if you need to leave early, you will receive a link to the recording within the next couple of days. That will come to you via email. Okay, good evening to everybody who's just arriving. It looks like the numbers are slowing down just a little bit. So good evening to everyone who's just logging in. I think we will make a start. So welcome to this evening's webinar from Veterinary Instrumentation. It looks like we've got really good numbers. I'm just keeping an eye on the numbers. People still logging in. So hello if you've just joined us. Looking at the registrations, as always, it looks like we've got a really good mix of first timers to VI webinars and also regulars who attend on a regular basis. So welcome to our webinar. My name's Rachel Beecham. I'm the training manager for Veterinary Instrumentation. If this is your first VI webinar, then a big warm welcome to you. This webinar series is proving really popular. So thank you to everyone who is here this evening. So before we start the webinar presentation, I'm just going to highlight a few bits as to how this evening's going to run. There are going to be some interactive multiple choice questions that our speaker Colin has concocted for us. So these multiple choice questions are to encourage your interaction and to help us to understand our audience better. Now, ideally, with those interactive questions, you would be on a desktop rather than a mobile. I think mobile loses a bit of functionality. So if you do have the option to be on a desktop, that will be better. Questions are very welcome and definitely encouraged. The Q&A is open. I can see some questions already. I'll have a look at those in a minute. Our colleague Simon Wheeler is online with us this evening as well. Simon's going to be keeping an eye on the Q&A and he'll be posing questions to Colin either at the end of the webinar or possibly as we go through if there are appropriate questions. The webinar is being recorded. Everyone who's here this evening will receive a link to the webinar recording within the next couple of days. And everyone who's here live this evening will also receive an attendance certificate for your time. So tonight's topic, as we can see on the screen, is monitoring of vital signs in veterinary anaesthesia. I've had a sneak preview of this presentation and we've got heaps to get through. So it gives me great pleasure to introduce our speaker for this evening, Dr. Colin Dunlop. Colin's a graduate of the University of Sydney and he's a specialist in veterinary anaesthesia. His career path is distinguished and varied. House surgeon at the University of Glasgow, resident in anaesthesia and critical patient care at the University of California, Davis, assistant professor of clinical sciences, associate professor and chief of the anaesthesia section at Colorado State University. Colin is a diplomat of the American College of Veterinary Anesthesiologists, and his research interests include prevention of anaesthesia, morbidity and mortality. He consults in anaesthesia and critical care for both small and large animal practice, biomedical research, and he provides continuing education programs for vets and vet nurses worldwide. So I think without any further ado and any more chat from me, I'll hand over to you, Colin. Thanks very much.
Thanks, Rach. I don't know where you found that, but that's an earful. I hope you haven't oversold it. Okay, well, we'll get started. The first PowerPoint is a picture of Harvey Cushing. And Harvey Cushing is most well known for being the person that Cushing's disease is named after. But Harvey Cushing was a neurosurgeon working in Boston from about 1900 to about 1935. Harvey is famous for a number of things. First, he was reasonably successful with his neurosurgery, and that was in part because he believed in fastidious aseptic technique. He, whilst working in old style surgeries with the slab in the middle and the audience in the seating, elevated seating around the edge of the room, he banned all that and was concerned about the care of patients. In about 1910, he went to Italy, met Mr. Rivarocci and learned how to measure blood pressure, brought that back to Boston. And he was the first person to continuously or have a person monitor the blood pressure of his patients during surgery, to have another doctor monitor the anesthesia of his patients, and to keep anaesthetic records of the patients. And there's one of his records on the left with respiratory rate, heart rate, and blood pressure on that record. So we owe a certain amount to Harvey in the anaesthesia world as well as the neurology world. If we look at where we've come from, the picture on the left, that's a picture that was given to me by Dr. Bruce Heath, who I work with at Colorado State, and it's of a dog anaesthetized at Ohio State at around the late 50s, early 60s. The dog's anaesthetized with pentabarb on a table, not intubated, tied down, probably because it was going to move. And it's a fairly crude anaesthetic, but it's what we did and what worked. And then as we develop things get better, and we start to monitor patients and take more interest in the welfare of the patient. So I think today we're more concerned about physiologic well-being of animals than perhaps we were in the past, and also the functionality of our team, the environmental impact of what we do, and the cost of what we do, because obviously that impacts the affordability of the procedures that we operate in and do on our patients. If we look at problem recognition and anaesthesia, you know, we have a higher mortality rate in anaesthesia than human medicine, and certainly about 50% of that occurs in recovery, and that's something we should be interested in. There's probably more than 9, but there are certainly 9 major categories of problems we're interested in anaesthesia, and therefore things we want to recognise: depth of anaesthesia, response to painful stimulation, changes in body temperature. We've become much more concerned about hypothermia and maintaining normothermia, monitoring heart rate, oxygenation, ventilation, blood pressure, perfusion, certainly blood volume loss, and its management. These are the kind of things that we want to identify either by physical parameters, and they can be difficult to measure by physical parameters, or by the use of monitoring equipment. Probably the holy grail of anaesthesia is really to have a good handle on depth of anaesthesia. And unfortunately, that's one of the more difficult things to do. I used to say, teaching students, you know, if I walked up to a student and asked them what was the depth of their patient, and they go, oh, it's okay. And I say, but I'm going to hold a gun to your head, and if you give me the wrong answer, I'm going to kill you. And then you're going to say, well, now maybe I'm going to become a bit more concerned about how I assess that. We certainly can look at things like physical signs, but when we want to be perhaps a bit more quantifiable, we might be more interested in things like these kind of parameters that we see here, where we can see the PaCO2 rises with increasing anaesthetic depth, the blood flow falls, the mean arterial pressure tends to fall. I think historically we've relied a great deal, or we've wanted to believe a great deal, that heart rate is telling us something about depth. I'll talk more about that later, but what you see here in this particular group of research animals is that as depth of anaesthesia increases, or the animals get deeper, their heart rate rises. And I think the tendency of us is to believe that when the heart rate's high, animals are light, and when the heart rate's low, animals are deep. And that's clearly not that simple. We started looking at better monitoring equipment back in the early 80s, and at Colorado State University, where I worked for a while, we can see that we started using these kind of machines that measured pulse oximetry and capnography. We bought these machines because the faculty strongly believed that the use of capnography was important as a tool for assessing anaesthetic depth. The students didn't really get it, but they got pulse oximetry, at least they thought they got it. We never had to tell students how to put the pulse oximeter on, that once it started going, it was giving them some information about pulse rate and oxygenation. So I think some parameters we monitor are what I would call intuitive. We kind of get them. And some parameters we monitor perhaps need better understanding, although sometimes the simple things aren't that simple. So for example, pulse oximeter gives you a pulse rate. Everybody wants it to tell you about oxygen. The oxygen of animals under anaesthesia breathing high inspired concentrations of oxygen is generally not a problem. But pulse oximeters tell you a lot about perfusion, and we should use all that information. And then respiratory rate, most people understand capnography gives you something in terms of information about respiratory rate. They want it to tell you about CO2, although there are certainly errors of measurement. And indirectly, it probably is a good tool for assessing depth. This is some equipment being used to monitor an animal back in one of the referral hospitals that was one of the early referral hospitals in Sydney. And what we see here are a couple of nurses working on a patient with some fairly basic monitors that were available at that time. The important message of this picture is, firstly, we're keeping an anaesthetic record. We still need to keep this information and in a representative way that we can use in an instant in time. The second thing is that these equipment is all designed for human use, although in later times that blood pressure pulse oximeter monitor that you can see there was adapted with some changes for veterinary applications. But there are errors in association of using this equipment, some from the patient, some from the equipment, and some from the people using it. And we'll try to address some of those things tonight. I put this picture in here because it's a picture of a horse under anaesthesia using some of the same kind of equipment. And my comments are these. The ECG in horses generally gets the heart rate wrong because it counts the ST segment as a beat. The pulse oximeter is transmitting light through a tongue that's 1.5 centimeters thick. It always underestimates the real pulse oximetry oxygen value by about 5%. And during an anaesthetic, it can drop to a point that it's non-functional, reads 80 in a horse that's clearly not hypoxic. The capnograph has a 15 millimeter of mercury AA gradient, so it's a glorified respiratory rate counter. Unless you've got a blood gas, you can't believe the information from the capnograph. The facial artery invasive blood pressure does work. Non-invasive blood pressure on the tail of the horse doesn't work. So of all of the tools we've got here on this horse that we can rely on, if we were to pull the gun out and say, if you make a mistake, I'm going to kill you, the only two bits of information I'm going to use off that horse are the direct arterial blood pressure measurement and the arterial blood gas measurement, assuming they're all calibrated, apart from the physical things I can recognize. One of the comments I would make about that horse is you can see the horse's mucous membranes. The mucous membranes are pink because the horse has enough red cells. The red cells are oxygenated and there is blood flow. And I was talking to some veterinarians and nurses today about capillary refill time. The capillary refill time of a dead dog is 1 to 2 seconds. And anybody who doesn't believe that, next time you euthanize a dog in the practice, take 5 minutes, go have a cup of tea, come back, check the capillary refill time of that dog. What we should be doing is looking in the mouth, because the mouth is the only place, the mucous membranes, where we can see blood flow. So when the mucous membranes are pink, this horse has good blood flow. So the point of this is that this equipment is not designed for 500 kilo horses, and we're trying to adapt it to do a job it wasn't designed for. And the other extreme in vet medicine are very small animals. Without boring you, I want to make a couple of comments about biomedical engineering. The animal is analog. There are virtually no monitors that we use today that do not convert that information into digital information. So dots on the screen. Some sensors are digital, some sensors are still analog, but the analog signal gets processed to a digital signal that is manipulated by the software of the monitor, and we have no idea what it is because it's proprietary. So a good example are pulse oximeters. There is no pulse oximeter on the market today that is not altering, massaging the pulse oximeter value to get a stable reading without using software to adjust that signal. The other thing that occurs is that the electronic engineering is taking what is in effect the lower right type of graph. That's just temperature data coming in off temperature sensors in a particular array of equipment we were using for research on heated breathing systems. But you can see that in order to make that something useful to us, we've got to average those signals and present those signals on a screen like the lower right, or even better, turn those lines into some simple numbers that we as the anaesthetist can look up and see and understand. So we certainly have signal modifications made on capnography, respiratory and pulse rate and SpO2 inputs. And we have calculations applied to those signals for particularly things like NIBP, where oscillometric systems deliver systolic and diastolic numbers, but they actually only measure the mean. So the mean number is real and the rest are made up by whatever software and algorithm is put into that machine by the manufacturer. We take that data and we now present that to us as the anaesthetist. And that's a critical piece of, a critical step in the process, because we need that data to be presented concisely in a way that, for example, it's color coded so you can look at the screen and rapidly identify which is the blood pressure, the pulse oximetry, the respiratory values. We need it to be visible from a distance. We still have situations in vet medicine where people are not necessarily always sitting right there beside the head of the animal. So perhaps the person doing surgery needs to be able to look up and see the screen. So we need these things to be clear. And I think one of the dangers of modern monitoring is so much information is presented on the screen with numbers and colored lines and other things that we are in danger of having data overload. So we as the anaesthetist look up at the screen and sometimes we block out 90% of what's displayed there and focus on the one or two items that we can relate to. I think there are things that will improve and change as we move into the future. So one of the things that we can do with equipment now is we can use microprocessors to automate various steps. And one of those steps is what happens at the start of anesthesia. We connect the monitor to a patient. There's a lot of things changing. The monitor might be programmed for a dog and it's a cat. And so the first thing that happens when we connect the monitor to the patient is the alarms start to go off. So then the next thing we do is stop looking at the patient and go in there and turn the alarms off, or go in there and reset the high-low parameter values for that patient so that the alarms stop annoying us. And I think one of the things that we've done in one of the monitors we work with is put a single button in there that resets the alarm system. So whatever the numbers are on the screen at that instant in time, it's going to reprogram the alarm system by pushing that button to those numbers for that patient. And you could do that a number of times in the procedure. For example, once you moved into surgery and the animal stabilized, you might need to do that again. But these kind of things can be automated and they can make our life easier and allow us to concentrate on the patient rather than the machine. So let's talk about pulse oximetry first. Pulse oximetry is a relatively simple concept in terms of what we do. We have a sensor that transmits red light and infrared light through the tissue, picks it up on the other side, reads the light absorption, turns that into a pulse and an oxygen value. there's more smarts in a pulse oximeter than there probably is in the digital, in the old DVD player or VCR player that was attached to your television. So there's actually quite a lot of electronic processing in one of these things to make it work. What is it trying to do? 97% of the oxygen is carried on red cells. So the first thing is that we're trying to measure the oxygen on those red cells. So we're looking at the light absorption through the blood to try to understand the oxygen on the red cells, the relationship between the oxygen, the partial pressure and the hemoglobin saturation is shown on that graph on the right. It's an exponential relationship. And what we're interested in is where the graph goes flat at the top, which is above the 90% line. And that's what we would consider to be arterial blood, because we can run around the block now, have changes in the oxygen level in our blood, and we don't fall down. An important thing to understand on that graph is where is venous blood? And people want to think the venous blood's down here around 50%, but the venous saturation's up there between about 85 and 75%, in that area right about there. So you don't have to change the oxygen level very much, the percent saturation, to make the blood go from red to a darker color, but you need about a third of the hemoglobin to be desaturated in a normal animal, so where an animal has a PCV of around 40, before our eyes can recognize it. The saturated oxygen bound to the hemoglobin is carried in the blood by the blood flow. So we're interested in the saturation, and that's what the pulse oximeter picks up. We're also interested in the distribution of that blood to ensure adequate oxygenation, so we don't have an animal under anesthesia that has a normal pulse oximeter reading waking up that's blind because of a cerebral hypoxic event. One comment I'd make, what's the difference between a dog with a PCV of 40 to a dog with a PCV of 20? That dog of 40 has twice as much oxygen in its blood, because 7% of the oxygen is carried on the red cells. The pulse oximeter doesn't know the difference. The pulse oximeter is going to read the saturation the same in those two dogs. So it's important that we measure the PCV of animals so that A, it's normal, and B, we understand how that's going to influence the amount of oxygen that that animal has. So one way to treat poor oxygenation in an animal with a low PCV is to raise its PCV. How do pulse oximeters work? Well, they're pretty clever. If we put that pulse oximeter on our finger, it transmits red and infrared light through our finger. As the pulse travels through the finger, the amount of light changes, so the machine can generate a pulse. But the first thing the machine has to do is figure out how much of that light is absorbed by the tissue. So if you look at the graph on the right, there's an area from the baseline up. That's what we call the background light absorption. And then the machine figures out the pulse, and it picks the pulsations up. And then from the red and infrared light and the peak of the pulsations, it determines the saturation value. So if we took a knife and cut my finger longitudinally here and threw that bit in the bin, I'd have half as much tissue, half as much background light absorption. This line would come down half that amount, dragging this waveform down by that amount, which is going to pull the saturation reading down. So the saturation fell because of a change in background light absorption, not oxygenation. And the change in the background light absorption that happens in anesthesia is vasoconstriction, most commonly due to painful stimulation, but it could be due to hypothermia, perhaps drugs, some of the drugs we give causing vasoconstriction, reducing blood flow, and that alters the oxygen value. We put pulse oximeters in lots of places. I don't probably think you guys need to be told, but you know, you can certainly put them on the tongue, the lip, the ear. A good place on pale skin animals is right above the hock. They don't work so well in dark skin because it absorbs a lot of the infrared light. So here's a dog. So all of these anesthetic records are the same. There's a patient description up the top. There's the normal values pre-anesthesia across here. The drugs used for pre-medication induction. This is an anesthetic in 1997. And so at that time, we were using thiopentone and sometimes diazepam to reduce the dose. It doesn't really matter what this animal got. This dog is being spayed. And you can see that as we go through the surgery, the blood pressures, the little V's, the dots are the heart rate, the circles, the respiratory rate, saturation's recorded, and below that, the end tidal CO2. And what we see is as we hurt this dog, pull on the ovaries, the blood pressure and heart rate go up, the oxygen drops a little bit. We see that happen again. And so these are responses to painful stimulation that are causing a change in catecholamine levels, which then cause some vasoconstriction, and the mucous membranes perhaps go a little paler, and the SaO2 drops a bit. Is it real? Well, one way we can test to see it's real, if that was a critical drop down to say 85, the first thing we should do is look at the patient, make sure the animal is pink, has a pulse, and is breathing. The next thing we could do is say, well, we think this is a response to surgery. We could take the probe off, the sensor off the tongue, put it back on the tongue. And sometimes people say that's because the sensor's squashing the tongue. What you're actually doing is resetting the background light absorption calibration on that machine. So if you do that, and there was less blood flow in that tissue than originally, the machine should reset itself and give you the same saturation reading it was giving before. And you can see that that's what's happened in this animal. One of the problems with new pulse oximeter technology, it's designed to dampen out that response. That's a very good response to see in anesthesia because it tells us something about blood flow and it tells us how our animal's responding to painful stimulation. But a lot of new pulse oximeter technology tries to process the signal and damp that out. So we've got this information from this dog. Tandy's SpO2's dropped to 89%. And if our goal is to keep the arterial saturation with oxygen above 90%, the question I want to ask is, what SpO2 value should we set as the low alarm value on our pulse oximeter?
So that question's just appeared on everybody's screen. Colin, you should be able to see people's answers coming in.
Okie doke.
So quite a spread of answers. The answers are coming in pretty quick. That's about 40% of the audience now, 50% who've submitted an answer. So we'll just leave that up for another.
I'm going to talk while people are answering because I can see the trend here. If you remember back to that sigmoidal graph, the 90% saturation point was where the graph became flattened. That's what we call the arterial saturation. That is the SaO2, the saturation of the arterial blood. The pulse oximeter is on the peripheral tissue of this cat or dog, the tongue, in our case, our ear. The pulse oximeter is looking at a capillary bed, not arterial blood. That's why it's called the SpO2. It's the pulse oximeter oxygen reading, not the arterial saturation. And there's already some venous blood in there. So these machines underread the real saturation by 2 to 3%. So when the pulse oximeter is reading 90, 92, the animal's really at 96. We put these things on a lot of anesthetized animals and get readings of between, I would say in dogs, 93 and 97, cats, 91 to 95, when the actual saturation of that animal is 100%. So the pulse oximeter underreads the real saturation by 2 to 3%. So if you wanted to know where the 90% SaO2 point is, it's going to correspond to about 87% in a dog. A cat might be a little bit lower because pulse oximeter readings tend to underestimate in cats a little bit more because there's less tissue and less flow. So I normally set my pulse oximeter low alarm level at 87%, which corresponds to an arterial saturation of 90%. I hope that explains the answer. So the right answer is to get it above 90%. but that's the arterial blood. Okay? Let's move on. Rach, I can't make the slide advance.
Are you using your arrow keys?
Yeah, it's since that little question. Let me shut this question off. There we go. Maybe this will work. It's stuck.
Can you try going back and then
There we
forwards
go.
again?
Perfect.
There we
Right,
go.
next case. George. George is an 8-year-old terrier. He's been anaesthetized to repair a radius and ulnar fracture. He's going to have a bupivacaine block put in. We connect him up to the anaesthetic machine. So he's been intubated, connected to the machine. We've put the sensors on the dog. We're getting an oxygen saturation of 75. So nobody's going to argue about whether that's low. It's certainly below 87. And we're not getting an end-tidal CO2 reading. What do we do with this dog? The saturation in this dog is more than 10% below what we'd like the arterial saturation to be. So we'd like it to be 90, it's 75. Believe it. This has got nothing to do with blood flow. This is real. This dog's oxygen saturation is low. We should check his mucous membranes to make sure, either convince ourselves that he's grey, or alternatively, if he's not grey, then there's something wrong with the machine. We should make sure he's got a regular pulse and ideally that he's breathing. I can tell you this dog's breathing normally, although perhaps taking a little bit bigger breaths than normal. We don't have an end-tidal CO2 waveform. So if we go to the next page, we've got this information. And my question is, what's most likely going on with this dog? So I've given some choices. The most likely thing is something to do with this dog's airway. We've induced anesthesia, the dog is still breathing, connected him to a machine, and suddenly his oxygen's really low. So he could have an obstructed airway, he could have something wrong with the way he's been intubated, he could be disconnected. If he's disconnected from the anaesthetic machine, he's disconnected from the machine such that the capnograph is no longer is attached to the machine, not the dog, not the endotrach tube. The reality is, all of these, and there may be some other answers I haven't, some other questions I haven't asked, but all of these are potentially options for why this dog has a problem. If the endotracheal tube was blocked or kinked, it would have to be complete for there to be no end-tidal CO2. And this dog is still breathing. His chest is moving, he's not distressed. So I don't think he's got a blocked or a kinked tube, because it would only be partial, in which case we should see end-tidal CO2. For the tube to be inserted too far into one main stem bronchus, the problem with that is that one side of the dog's lung is in effect breathing room air in and out, and the other side of the dog's lung is connected to the side of the lung that's intubated. So we should still see end-tidal CO2 and an end-tidal CO2 waveform. And in this dog's case, he's got no end-tidal CO2 reading. It could be that he's intubated and disconnected. I would be concerned that a dog breathing room air, even though he's just been anaesthetized, should have a higher SpO2 than that. So that leaves us with esophageal intubation. And in fact, that's what was wrong with this dog. This was a dog that some students anaesthetized. I was standing right beside them, and they closed the pop-off valve on the anaesthetic machine and gave the dog a breath. And it appeared to me as though the dog's chest rose. So then they waited 30 seconds and gave him another breath. And then I realized the dog's taking additional breaths in the middle of this, and we're having no effect on the dog's saturation. And in the meantime, the dog's pulse rate starts to decrease a bit. And I think that's because we've inflated his stomach with air. So we got in a laryngoscope, took a look down the back of his throat and realized the tube was in the esophagus, replaced the tube. And if we go back to the record there in a second, we will see that we immediately fixed this dog's oxygenation. So these answers could all be right, but logic would say if we've got an end tidal CO2 reading, then we'd be more concerned it would be the top two or the bottom one if there was no end tidal CO2 reading, but we can see the disconnection, and then that would leave our other option being esophageal intubation. The other question that I asked there is what parameter would best diagnose the problem? And I can't see the answers, but I'm assuming that the majority of people have answered the capnograph. And capnographs were invented, as they came out of human medicine in the early 1980s as a tool to ensure that humans were not esophageal intubated, because a human is paralyzed under anesthesia. So if they're paralyzed, intubated in the esophagus and connected to a ventilator, and the stomach is going up and down with the ventilator, then you can be fooled into believing that person is intubated correctly, and then they have a hypoxic injury or die. So capnography was developed for that very purpose, to ensure that when the patient is intubated, you connect the capnograph and you can see CO2. And that is the best way of ensuring that you've got a functional airway. Okay, next one.
Colin, can I just interrupt? Where we've got two questions on the box, you should be able to just scroll up and down on the side of the box, and then you'll be able
I see, and I'll see it.
Answers.
Okay, yeah. Great. Did I read correctly that most people have said end tidal CO2?
68%, yeah.
Excellent. Okay. Right. Next. There we go. So this is just to remind you all that the point of how far we should intubate animals is to the point of the shoulder, that when you inflate the cuff, it's really a process of a couple of people giving a normal breath, inflating the endotrach tube cuff to block a normal breath to 12 centimeters of water. There are devices you can use that supposedly measure the pressure. We tested a bunch of them about 6 months ago, and I wrote something on the ACVAA listserv about it, but they give quite varied results. One, this dog here in the radiograph, you might be able to see there's an endotrach tube down there in the airway and it's not in the upper airway. That's because this dog woke up in recovery and bit it off. So we've now got some endotrach tube stuck in the dog, and how do you get that out? You re-anesthetize the dog, get a smaller tube, stick it down the airway inside the bigger tube, blow up the cuff and pull it all out. Okay, and I just tell you that because I've had to do that a number of times. I don't know if I've caused it, but certainly I've seen that. What about heart rate as a parameter? So we move on from pulse oximetry, and pulse rate is important in anesthesia. And as I said before, and you look at these graphs on the right, there's a group of dogs going from light to deep anesthesia with fairly big falls in blood flow, cardiac output, and mean arterial pressure. But in fact, the heart rate rises a little bit. So dogs are funny animals. They're parasympathetically driven. That's why dogs get sinoatrial rhythms with breathing. As they breathe in, they stretch their lung, get some vagal outflow, and that slows down their heart rate. We don't see that in horses. We probably don't see it very often in cats. But if you've got a parasympathetically driven animal, as you anesthetize them, you release that parasympathetic inhibition and their heart rate rises. But at light levels of anesthesia, they can also have parasympathetic activity that slows their heart rate more. If the animal's light and you hurt it, it can release catecholamines, and that can cause the heart rate to rise. But that tends to be quite a rapid rise, but for a short period, 30 seconds to a minute or so. So the point being that there can be quite varied heart or pulse rate responses in animals in anesthesia. So we should monitor the pulse rate. We can pick up the pulse from the plethysmograph on a pulse oximeter, from a blood pressure waveform, particularly if there's an arterial line, or we can look at the ECG. The problem with the ECG is not a pulse. The ECG is an electrical activity. If you euthanize a horse, it'll have a normal ECG for 20 minutes. If you euthanize a dog, some dogs will have a normal ECG for 5 to 10 minutes. So an ECG is electrical activity, but it doesn't tell you there's been a heart contraction or an injection of enough blood to create a pulse. But all of these devices are used to give us an assessment of pulse rate. And if we look at this next case, this is Sky, and Sky's a 9-year-old Maltese. Now, Sky's got GME. So Sky has some underlying intracranial disturbances that potentially of themselves can cause some issues for this dog. But Sky also has a ruptured eye that's going to be enucleated, so quite a lot of ocular pain. And you can see there that about 45 minutes into this anaesthetic, probably at the time the surgery starts, this dog's heart rate starts to fall. It was never that high to start with. The dog's resting heart rate, I don't have it on the record there, but it's in the, where did I have it written down? Down the bottom, I think. And the resting heart rate was around 55 to 60, probably reflecting the ocular pain and maybe the underlying GME that this dog has. But during the enucleation, it drops slowly from 60 down to about 40, and then quite suddenly drops down to 20. And at this point, we should be becoming concerned about this in this dog. We look at the end-tidal CO2 waveform, the SpO2, they seem to be okay. Maybe we're going to stop the painful stimulation, treat the vaguely mediated bradycardia in this dog. This dog actually did have a brief period of asystole. And so while we were treating the dog, we did actually give its chest a couple of extra heartbeats by manually squeezing its chest. You can see down there, the end-tidal CO2 reading drops as the pulse rate drops, the oxygen drops a little bit. So this is a dog that's developed a bradycardia during a surgery, quite a common event, perhaps not quite that severe. And if we go to the question, my question is, how would you respond to this patient? So that's the first question. And there's the questions. So we could check the SpO2, commence cardiac compressions, turn off the isoflurane. We could stop the surgical stimulation and ask the surgeon to improve the analgesia if we don't have a block in this patient already. We could check the end-tidal CO2, commence cardiac compressions and turn off the isoflurane. We could check the end-tidal CO2, and I can't read all the last question there. Can you read that, Rach?
You should be able to make your box bigger, Colin.
Oh, I see. All right.
Drag it out to the side.
Now I can see, yeah. Okay. And we could give the dog some adrenaline in the third choice or some atropine in the fourth choice. And then at the bottom question is which parameter, which thing that we're monitoring there is going to pick up lack of blood flow or a cardiac arrest the fastest. So what I can see there in the top as people are answering is that there's a bit of a mixed range of answers. So clearly there's not absolutely a right way to treat this animal. Potentially a number of these things could work. What would I do? That's the good question, because it looks to me like we're getting about an even range of answers. Okay.
That's just over half the audience have answered. It looks like those are slowing down. So I will just end the poll and share the results.
What you can see here is a range of things. Let me start with the bottom one. Would I give, sorry, the third one, I'd check the end-tidal CO2, commence cardiac compressions if the dog doesn't have a heartbeat or a CO2 reading, probably turn off the vaporizer. And would I give this dog adrenaline? Would adrenaline work? Possibly. Yes, is the answer, it would. But there's always the possibility you might make this dog fibrillate. And if you're in a practice that doesn't have a defibrillator, you might create a new problem that you can't correct. So my inclination would be to use atropine first, because the atropine, if this is simply a parasympathetic problem, should fix it. And I've got a lower risk of fibrillating the patient. So my inclination would be to lean toward atropine. The top answer is also similar, except it says to check the SpO2. Now, what I'll do is answer the bottom question. The bottom question is, which thing picks up a cardiac arrest the fastest? And the answer is clearly a capnograph. If you have no blood flow through the lungs, you have no CO2. A capnograph is going to pick up the cardiac arrest in one heartbeat. It's going to read 0. The pulse oximeter will eventually become desaturated so that and or have no pulse and pick that up. And it might take a few beats to 30 seconds, or in some cases a minute, depending on how much signal processing that pulse oximeter has. So some pulse oximeters will look for the pulse first, then set the alarm off to say, I can't find the pulse. So the capnograph will be the fastest. So therefore, when I look at the 4 questions above, whilst the top question's not, the top answer is not necessarily wrong, the capnograph is going to give me quicker information and better information than the pulse oximeter in an immediate cardiac arrest. Now, I might, if we've got a minute or two at the end, talk a bit about CPR, and you'll see that both of those devices are useful. Okay. What I've got to do is shrink this thing up. Oh, okay, good. There we go. And I just put this in here. One of the things that we've developed over a period of time is an appropriate methodology for responding to problems. So we should use the same structure for problem solving all the time. So it becomes a method, not just what are we going to do today. So we should define the problem, a heart rate below 30% of the resting heart rate. Recognize the problem with whatever pulse monitoring device, which could be a stethoscope. The best clinical assessments, well, they vary, but continuous pulse monitors, any device that monitors the pulse rate or the heart rate. And then what are the causes? Well, we've described the parasympathetic problem in this dog, potentially deep anesthesia, potentially some anesthetic drugs like alpha-2s, potentially hypothermia. What should our first response be? There should be a big sign flash up on the monitor, look at the patient, stupid. So you go look at the patient, make sure it's got a pulse, that it's breathing, and that its mucous membranes are pink, and then you can go through the troubleshooting. So if the dog's had a cardiac arrest, we can do some things for that dog while we're doing the thinking. So we can construct that type of problem management algorithm for all the problems we deal with in anesthesia. So let's move on to capnography. And capnography was developed because in human medicine, firstly, we were concerned about esophageal intubation resulting in hypoxic injury. And secondly, because the end-tidal CO2 in a spontaneously breathing patient gives you an indication of depth of anesthesia. If you ventilate the patient, you take that tool away. And so we see here as depth increases, CO2 increases with a whole range of anesthetics. A surgical plane of anesthesia is about 1.2, 1.3 Mach. So about here somewhere, with a CO2 corresponding of around about 48 to 50, around 50. We could also measure the functional ventilation by measuring respiratory rate and tidal volume. That gives us the minute ventilation. So the minute ventilation in animals is around 200 mils per kilo per minute, which happens to be the flow rate, the fresh gas flow rate for a standard non-rebreathing circuit. Or we could measure the arterial blood gas, and that's certainly what we do in horses. So capnography is using some fairly simple looking equipment, a sensor, some kind of an airway adapter or a sampling tube coming into the machine where the sensor is located, to look at the gas, the expired or the inspired and expired gas and then using infrared light to look at the light absorption to determine the CO2. So in order for capnography to work, we've got to have an animal. So this dog breathes. We can see that the CO2 is down here in the alveoli. That CO2's got to come up to the point where we're going to sample it, which is the endotrach tube connection. So you can see that the length of tubing coming down to the lung, the trachea and airways, when the dog breathes in at the end of inspiration, that has room air in it. So when the dog breathes out, that gas comes out first. That's what's called the anatomic or the physiologic dead space. Then we've got this gas down here in the conducting airways, down in the bronchi and things, which is a bit of mixed gas, some CO2 in it. And finally, we get the alveolar gas. And we look at that waveform. It starts at 0, inspiration, the first third of expiration, which is the gas that never made it to the lungs, so it's still room air or inspired anesthetic gas. Then a rising CO2, those distal airways, and then that tall, flat part of the curve, which is the alveolar gas. And that's the gas we're interested in reading, the end-tidal CO2. And you can see, if you can look down and see on that monitor there, that was one of the early monitors we had that was a mainstream sampler, a very good monitor, and it's reading the CO2 in this dog of 44. There's the waveform on the screen. So you really need to see the end-tidal CO2 waveform to know that you've got a proper waveform when you are in fact getting end-tidal gas. And you can see some bumps on this one, which I'll talk about in a minute. And this is an artifact that we see in particularly small animals. So here's our first case that we're going to talk about. And this is Tarzan. Tarzan's a fairly decent sized cat. He's a weightlifter at 6.1 kilos. And Tarzan's been anesthetized to have some work done on his teeth. And his end-tidal CO2 waveform's showing up the top there. So it's a little waveform coming up that looks pretty good, except it doesn't have that flat alveolar bit on it. And so the question is this correct? And the end-tidal CO2 in this cat's reading 29, and then it goes up to 32, then finally to 35. So the first thing I've done is popped in a little table there, and you can see some, I've just looked, you know, if you want me to give you the references to where I can find those values, I can find you some references, but they're typical values that we would use. We would expect the end-tidal CO2 of a dog to be higher than a cat. The conscious CO2 of a dog is around about 40, 35 to 40. I've drawn that a bit fun. I've drawn that graph the wrong way around. I can see that. So the left-hand column, the 30 to 36, oh no, that's about right. That's the normal CO2 of an awake cat. 35 to 40 is about what we might expect under anesthesia, even a little bit lower than that. A dog, 38 to 44, around 40 to 42 is the awake CO2 of a dog, and that would be the arterial CO2. And under anesthesia, typically we get about 48 to 53, somewhere in that for a light surgical plane of anesthesia. So we can see that this cat's got a waveform with no alveolar plateau. And so the question is it real? Is the CO2 real? One of the problems that we have in small animals is dead space. And if you're going to use mainstream sampling, side stream samplers look like this connector up here with a little port in them. So they add a typical amount of dead space similar to a large mainstream sampler. And then we make pediatric mainstream samplers that have an internal diameter that's about equivalent to a size 5.5 to 6 endotrach tube. So we use that adapter on everything smaller than a size 6 endotrach tube, and it has a volume of 1.2 mils. So if I just had the cat, that adapter connected to the Y piece, if it was a standard Y piece, a standard adult Y piece, it would have the volume of the gas we have to rebreathe is this bit down here in the Y piece, and the adult Y piece, a 22 millimeter one, that would be about 5 to 7 mils. In a pediatric 15 mil Y piece, it'd be about 3.5 mils. And we make a new Y piece that you can see in this picture here, funny looking shape thing, and it only has about 1.5 mils of dead space. So if I use that Y piece and that adapter, I've got a total machine dead space of about 2.7 to 3 mils. which for this cat's probably okay. Whereas if I put this cat on an adult Y piece, I've got 5 mils with a 7 mil connector, that's 12.5. And if I added an elbow connector, I've almost added 10 more mils. So dead space matters, particularly in animals under about 5 kilos. So if we go to the questions, Tarzan's breathing without any problem. He's breathing quite well. He's got a nice end-tidal CO2 waveform with what looks pretty good, except it doesn't have an alveolar plateau. And the question I've really got is, what is the most likely cause for this waveform to not get an alveolar plateau in this cat? So what is special about a cat when we put a capnograph on a cat that causes it to give us an end-tidal CO2 waveform that is not that classic nice waveform with an alveolar plateau?
I'm just going to jump in as requested, Colin, and give you your 8:25 time
Okay,
check.
thank you. I'll have to pick it up. Right. So I'm watching these answers coming in, and I can see some people are picking some individual things and some people are saying all of the above. And I would say that all of the above could account for it. So if you've got a cat with a high respiratory rate, you end up with a relatively small tidal volume, a small gas sample. So you end up with that inadequate sample, meaning we don't get some alveolar gas. If the cat has a non-rebreathing circuit with a high fresh gas flow and the fresh gas comes in at the endotrach tube connector, that creates a Venturi effect. It sucks some of the gas up the airway, giving us an inspired reading, but it also washes away the end tidal gas. So that could cause the problem. If we have an unsealed endotrach tube or the cuff isn't sealed, when the cat breathes in and out, some room air gets in there and that can damp out the signal. And finally, the cat itself doesn't have that big of a tidal volume, although this cat's a decent sized cat. And depending on how much equipment dead space we add to that, that could cause us not to get an alveolar gas sample. So all of those things could do it. And in this, the other question I asked is, how much dead space could we reasonably add to the system, bearing in mind that in a normal animal, 1/3 of its tidal volume is dead space. So I can scroll down and see all the animal, all the answers. Bearing in mind that 1/3 of the tidal volume in a normal animal is dead space, right? So this cat's got a 6 kilo cat, 10 mil per kilo tidal volume is going to give it a 60 mil breath. 20 mils of that is the airways. So we're left with 40 mils of gas that potentially can make it to the lung. How much of that can we take away? Well, in a 3 kilo cat, it's 30 mils less 10 is 20. That's the amount of gas we've got to work with that can get down to the lung. If we took half of that away, the cat would still have some alveolar ventilation, not as good as normal. So my answer would be, you can probably take half the tidal volume and that could be rebreathed and the animal will still have alveolar ventilation that is going to be acceptable. Maybe that animal will increase its respiratory rate a little bit to compensate for that. But if you take away more than half the tidal volume and turn that into physiologic and equipment dead space, the animal will start to run into problems and it'll eventually either not get enough anesthetic and wake up, or its CO2 will rise. So in this cat's case, I think we could add, in our cat's case, if he's a 6 kilo cat and he's got a 20 mil a normal, he's a 6 kilo cat, you could potentially have half of that 60 mils as dead space or rebreathed gas. 20 mils of it is the cat, that leaves you about 10 mils. So the answer could be 7 to 13 mils. And I would say either of those would be right. The 3 mils, I can perfectly get it that people think, well, we've got to keep it as small as possible. But relatively speaking, this is a pretty decent sized cat. If it was a 3.5 kilo cat, then I would definitely say 3 mils would be about the right answer. Okay. Right. Okay. There we go. Non-rebreathing circuits, we get washout of the CO2. There's a waveform of a non-rebreathing circuit on the left. And what we've got on the right is a normal kind of looking waveform. How did we get that? Well, we either put the animal on a small volume circle system and get rid of the continuous gas flow of the non-rebreathing circuit. And that's all I've done with this patient. It's the same patient. And I've just swapped from a Bain circuit to a low volume circle system. Or if I had a Bain circuit like this, I could turn off the oxygen flow for 2 breaths, let the CO2 give us a normal waveform, and then turn the oxygen flow back on. Now, if you're going to do that, and I had the nurses do that at one of the hospitals I work at, never take your hand off the flow meter knob till you've turned it back on, okay? Otherwise, you're going to hasten that animal's demise. But you can see when you turn off the fresh gas flow down here on the bottom that we're going to get a much better end tidal sample with a much smaller error, 7.7%, compared to 21% when you've got continuous fresh gas flow from the Bain circuit. The next problem we see in small animals, but we can see it in big dogs as well, but animals where they're breathing spontaneously, is we can see these cardiac oscillations, these beats that are heartbeats. And 2 different machines are both showing us those cardiac oscillations. It can be quite difficult for capnographs to discriminate those things. So the machine gives us a respiratory rate of 44 when the animal's true respiratory rate is 14. So these things create respiratory rate errors, and they can also cause the end tidal CO2 if it's really 55 to read 55, 48, 42, 36, and then it'll come back up to 55. So you need to be able to see the CO2 waveform to understand what the information is that is on the screen. And if I had this problem in this particular patient, the first thing is you can't make CO2. So the highest value we get on the screen is likely to be the correct value. How do you get rid of cardiac oscillations? Well, you can improve that with signal processing, but also if you add a tiny little bit of PEEP. So the pop-off valve on anaesthetic machines shouldn't open till 2 centimeters of water. You don't see these things with ventilators generally, because ventilators have a pressure relief valve in them that doesn't open generally till 2 centimeters of water. And that 2 centimeters of water is enough to stop those little puffs of gas. And those little puffs of gas we're talking 0.5 mil per breath. We're not talking liters of CO2 here. So Chewin Maxwell, he's a dog that's been anesthetized for some ocular surgery. And what I want you to focus on Chewin Maxwell's case is his heart rate starts off at 120 and over a period of 5 or 10 minutes climbs up to about 140. His blood pressure starts at 80 and drops down to 60. His end tidal CO2 is at a 52 or 53, but it starts to go up. His oxygen is fairly steady at 95%. And what we see with Chewin Maxwell is a rising end tidal CO2 waveform. Now, the question I've got is, if we go to the questions, is firstly, his end tidal CO2 over another 5 minutes got up to 74. That's pretty high. And I guess the question with this dog is, what would you think is the expected range of end tidal CO2 in an anesthetized dog at a light surgical plane of anesthesia? So this is not an awake dog. This dog's anesthetized. And I'm seeing here that the majority of people, not all, but the majority of people are answering 48 to 53. And I would say that that is about the range of CO2 in spontaneously breathing dogs. 38 to 44 would be more typical of a conscious dog. Not many dogs under anesthesia have CO2s below 45. There's got to be a reason for that. and 60 is too high for a dog at a light plane of anaesthesia. It should have a CO2 below 55. If I walk past a surgery room and I look up and I'm looking at the screen of a capnograph and I see over 55, 56, 57, 60, I'm going to walk in and take a look at that patient. 70 is way too high. What about a cat? How would these values differ in a cat? Well, we've already talked about the cat's capnograph on the previous case, and the capnographs of cats generally underread because it's more difficult to get an alveolar plateau, but also cats have lower CO2s than dogs. So cats will breathe quite happily against a ventilator with a CO2 of 35. A dog would never breathe against a ventilator with a CO2 below about 42. I won't say never, but it's unlikely. Okay? All right, let's move on. Right, what about Sam O'Donnell? So here's Sam, and the important thing about Sam is that Sam's anaesthetized, things look pretty good. Heart rate's 100, blood pressure's about 100, pulse breathing's okay, saturation 96, 97. That's pretty good for a pulse oximeter reading on dog, although he's got fairly injected mucous membranes, but his CO2's going up 47, 49, 53, 60. And then we really take a look at the record in that same period, and what we see is the blood pressure keeps going up and the heart rate keeps going up. So the question is, what's going on with this dog? The other thing that we can see is that it's not recorded there, but this dog had an inspired CO2 that started at 1 or 2, and by the time the end tidal got up to 60, was reading 5 millimeters of mercury. So if we go to the questions, my question is, what is the least likely cause of Sam's problem? So is Sam least likely to be light? Is he least likely to be responding to hypoxemia? Is he least likely to have an inadequate fresh gas flow rate? Is he least likely to have rebreathing of CO2? I should have probably asked that question, what's the most likely cause, but I just don't know why, but I asked it in the other way around. And it looks to me like people are probably answering that question, what is the most likely cause of Sam's problem? That's what I would say, because it's a little bit confusing the way I asked it. Let me run through those answers. Inadequate anaesthetic depth. So is Sam getting light? And there are no signs of the dog moving, but the parameters of that dog the blood pressure and heart rate would certainly have you believing that this dog could be getting light, except the dog has a rising end tidal CO2. If the dog was getting light, his end tidal CO2 should be falling back down to that sort of 40 level. What about a response to hypoxemia? Certainly, if animals become hypoxic, they become tachycardic, they can become hypertensive. They're likely to breathe well. No animal dies of hypoxia without trying to breathe. So I'd expect the CO2 to go down. I wouldn't expect the dog to have injected mucous membranes. If the dog had an inadequate fresh gas flow rate to a non-rebreathing system, if it was a non-rebreathing system, then you potentially would have a rise in CO2. There's enough oxygen there to keep the dog oxygenated, so you might see that kind of presentation. Or if the dog is rebreathing CO2 due to something wrong with the breathing system, the CO2 absorbance is exhausted, there's no valve, so there's rebreathing of CO2. So the most correct answers are the bottom two. I would say the least likely answer is the second one, which most people have said is unlikely, if the answer is what's the most likely cause. So I've perhaps confused you a bit with the question. Which parameter confirms our diagnosis? Definitely the capnograph. So the capnograph is going to tell us that this dog has a problem with inspiring CO2. And if we just go back to the record for a second, I think I can go backwards one here. And what happened in this dog is we changed the CO2 absorbent, and very quickly you can see his heart rate comes down, his blood pressure comes down, and his CO2 starts to drop. Okay. Capnograph sensors, just one comment. You do need to zero or calibrate main and side stream capnographs. And if you've got a mainstream sampler, that's the little airway adapter here. If they develop a crack across the top, which is a fatigue point in those adapters, the light travels through that crack and it's not going to read properly. So you put the capnograph on the dog and it's reading the CO2 at the start of anesthesia, 2 breaths into it, it's reading 74 with an inspired CO2 of 5 millimeters of mercury. And I would check the adapter, and I would certainly look at the patient and make sure it's breathing regularly and it's pink mucous membranes. And then I would be looking at that adapter. And if that's not the problem, I'd calibrate the sensor. You got to calibrate the sensor, not on the patient. What about blood pressure? We'll finish up with this and I'll have to go fairly quickly, but with blood pressure, what we see is we measure blood pressure because it tends to decrease with increasing anesthetic depth. When we look at the blood pressure waveform on the bottom right, systole is the peak, diastole is the bottom, the mean is the area under the curve, not the average of systole to diastole. Actually, the systole is the filling phase. So the systole is this whole section here, and the diastole is systole is the ejection phase, diastole is the filling phase. So we spend more time in diastole than systole. So if we want to calculate the blood pressure, the mean pressure is the area under the curve, or we've got to calculate the area of this as 2 triangles. So we're going to take the diastolic pressure and add 1/3 of the difference. The other thing that I've got a picture here is of a heartbeat and a cardiac cycle. The heart beats in systole, shoves the blood out in the aorta expands, the heart relaxes, the reflected wave snaps the aortic valve shut, and the elastic recoil forces the blood out during diastole. So diastolic flow and pressure is generated by the elastic recoil of the aorta, which means there's got to be enough blood ejected to distend the aorta. The aortic valves have to shut, and that's what creates the forward flow in diastole. If you've got a PDA and you have a leak from here across to the pulmonary artery, you lose this volume, and that's why PDAs have high heart rates, because they're trying to compensate for the lack of forward flow by pumping more times per minute. We measure blood pressure with all kinds of devices and oscillometric devices. A whole lot of different devices use the same fundamental technology, and that's a CAS Medical designed blood pressure module from about 1985, and the thing is bomb-proof. And that thing is inside a lot of monitors. You do have to calibrate these monitors. These devices, oscillometric blood pressure, is looking for the pulsations in the cuff or the artery at the point that the occlusion is going from fully occluded to release. And these vibrations are only about 2 to 3 millimeters of mercury. So when we measure blood pressure with auscultation, we're looking at systole. With palpation, we're looking at the point where pressure returns, again, systole. This is what a Doppler is picking up. A Doppler is a pulse occluder. Oscillometric pressure determination are looking at these little oscillations, and it's looking for this midpoint in the oscillations, and that is the mean pressure. And what oscillometric is kind of doing is like this guy with his whip through the board where there's a hole, and it's the sine wave is turned into this little vibration, and it's that vibration that the machine is trying to pick up. If we let down the blood pressure cuff with a Doppler in a cat, what we're relying on is the Doppler, the rate of deflation in the cuff, picking up the peak systolic point. And the problem in cats and small dogs is that this peak is very narrow and we often can't pick that up. It's not big enough. There's not enough change in sound or pulsation there for us to detect it. So we come further down into the waveform down here and we pick that up. And so this is work we did years ago looking at the error of measurement of Doppler versus direct pressure. If this was accurate, all these dots would be on the solid line. And if that was the case, this thing would be quite accurate. So in anesthetized cats, the error of reading of a Doppler is about 14 millimeters of mercury. And in fact, it's possible that Dopplers are in cats getting closer to the mean pressure because of this narrow waveform with a high spike on the systolic waveform. Where do we put cuffs? Well, I just jumped on the internet some time ago and I put in blood pressure measurement in animals pictures. And I got all of these pictures, 18 pictures on the thoracic limb above the carpus, 2 pictures above the elbow, 2 on the tail, 23 on the thoracic limb above the dog's thoracic limb above the carpus, 3 above the hock, and 3 on the tail. Clearly, you can put them in lots of different places. The question is, are they right? Now, while you're all sitting there, I want you to take one hand and put it around your wrist, with your wrist just limp like my wrist, and pretend that your other hand is a cuff. And then I want you to make a fist and feel what that cuff feels. Then I want you to relax the wrist and bend your wrist. And you're going to see that the pressure in that cuff is going to depend a lot on the pressure of what happens in that limb. So the more mobile the limb, the more likely it is that those effects, those positional effects, are going to alter the ability of that cuff to transmit the pressure from the artery into the cuff for the transducer to pick it up. What our research over a long period shows is that the best correlation that we get, the most reliable correlation between direct pressure and the non-invasive pressure, is a cuff above the hock in most animals, not necessarily little bent leg dogs like Daxies, and not sighthounds. Sighthounds, the base of the tail is better. The problem with the forelimb is that when you extend that limb in surgery, particularly if it's pulled out to position the animal, you're causing pressure on that cuff that is mechanical, and it's going to make it more difficult for that cuff to pick up the true blood pressure. This is a little dog just showing cuffs in 3 or 4 positions in this dog, and this dog weighs 2 kilos, and you can see that we are getting different readings depending on where those cuffs are positioned, and the reading that is the most likely to be closest to the arterial pressure in this little guy is going to be this reading on the back leg above the hock. Which animals can we get the reading of blood pressure most close to a human, which is above the elbow? Any marsupial. So if you come to Australia, catch a kangaroo, measure its blood pressure, it's more likely to be real than in a dog. Okay. What about human blood pressure measurement? The point of this is the American Heart Association's guide to how to measure blood pressure in a human. There's a method to it, a very specific method with a bunch of steps that they follow. They get trained to measure blood pressure. We don't. We grab the animal, stick a cuff on a hairy leg, a bent leg, and we hope for the best. And we don't really train people into the methodology. So it's no wonder that we have a lot more error of reading than in human medicine. In human medicine, in neonates, the error of measurement is about 15 to 20% greater than adults. So as you get down to even smaller humans, there are greater ranges of error of measurement. When we put cuffs on, all I want to say about these cuffs is that the way that cuff inflates on the limb, the way it's positioned on the limb has a lot to the transduction of pressure. So this one on the bottom right that is a soft cuff blows up like a sausage is the force of this cuff is out, not down. So what we want is when the cuff is positioned and to be inflated, for that cuff to inflate flat on the limb, as flat as possible. So then it's receiving the pressure from that length of artery up into the cuff, particularly when we're trying to measure these 1 to 2 millimeter of mercury oscillations. Another problem we have in vet medicine is the range of cuffs. We actually make a range of cuffs with 7 cuffs in that range. Why do we do that? We anesthetize a lot of animals down below 3 kilos, and the smallest human cuff is only designed, that is the smallest human cuff, and it's technically designed to measure a circumference bigger than 5 centimeters. That's a fairly, if you're talking about ferrets, rats, rabbits, things like that, they're all down here. So we make a cuff that gets down a little bit further. We can't make a cuff go much smaller than that because it doesn't have enough volume in it for the machine to work with. The other thing you can see here is that the cuffs should overlap. So here's a human 1, 2, 3, 4, 5. There's no overlap here between a 2 and a 3. If you measure a cat, the ideal circumference of a cat's limb, forelimb or hind limb above the hock is about 8.4 centimeters. So the problem with cats is they're too big for a size 2 and too small for a size 3. So we make a specific cuff to fit cats. And it's the width of the cuff that matters, not the length. And so here's a range of this as a scale that's developed for this range of cuffs with 40% plus or minus 15%. And here's the same scales measured basically from human cuffs that are taken off the human cuff. So they actually tell you you can use the cuff on a smaller size than the cuff is actually designed to work on. What happens when we measure pressure? Well, okay, let me give you 2 simple examples. Garfield is anesthetized to give us a blood donation for an animal that's bleeding out in surgery. So we needed quite a lot of blood. Normally in a cat, we'd only take 50 to 60 mils for a blood donation. But in fact, in Garfield here, we took 100 mils of blood. So we took out the first 50, not much happened. Then we took out the next 50 and Garfield didn't like it. And this cat's had a substantial and sudden drop in blood pressure, not much change in respiration, a little bit of a drop in heart rate. And so the point being that measurement of blood pressure, particularly in animals where things like depth or volume are changing, matters. If we go to our question, Garfield's a 3.5-year-old young, healthy 7-kilo cat with a normal PCV. He's lost 100 mils of blood. I'm giving you his blood volume. I'm telling you his blood volume is going to be around about 65 to 70 mils per kilo. So he should have about 500 mils of blood. So my question for Garfield is how much fluid should we give him to treat that 100 mils of blood loss? And then if you've got that answered, then maybe you might think about how fast should we give the fluid to this cat. So this is crystalloid fluid, Hartmann's lactated rings. Okay, so we can see a range of answers there. Garfield's lost 100 mils of blood. The fluid we're giving him's got no protein in it. It's got no plasma. So there's nothing to keep that fluid in the vascular space. And the relationship between the intravascular and the interstitial volume is about 1 to 2. So for every mil we give that cat IV, 2/3 of it is going to go into the interstitial space. So we're going to need to give Garfield somewhere between 2 to 3 times the volume of blood loss if we're going to use crystalloid fluid. If we were going to give him plasma, then 100 mils would be the right answer, okay? He doesn't need 540. He probably needs 200 at a minimum and 300 at a maximum, somewhere in that sort of range. How fast do we give it? Well, some people say you could give it as fast as he lost it, as long as you were using plasma, because it would be volume for volume. Because we're giving him a bigger volume, we probably want to give the fluid in a longer period than 10 minutes. We give some over 10 minutes, and then we probably want to give some more slowly. Now, I can see there's the commonest answers are either to give him half over 10 minutes and half over 30. I'm not going to say that's wrong. Or we could give him a third in 10 minutes, a third over 30, and a third over 2 hours. If we looked at his normal IV fluid rate at 10 mils a kilo, which is a fairly, I think we use more conservative doses of fluid these days, mostly around 5 mil per kilo per hour. So 10 mil per kilo per hour is still close. So a maintenance fluid rate for this cat would be about 50 or 60 mils an hour at 10 mils per kilo per hour, or 25 at 5. So we could give him 100 mils over 2 hours if we use that flow rate. So I would say either of those answers would be acceptable. I'd probably lean to the bottom one, as long as the cat has responded adequately to the first two. So if, in other words, the first bolus of third over 10 minutes and then a third over 30 minutes. So I go back to the cat, and let me just jump back to Garfield, and we can see that he's responded to about 120 mils of fluid pretty well in 20 minutes. So you could then put that cat at that point on that maintenance fluid rate of about 50 mil an hour while he's waking in recovery. But if he hadn't responded like that, you'd want to give him more. Okay, so it's not an absolute right or wrong answer. And the last one I want to talk about, and then we'll finish, is Jaffa. And all I want to say about Jaffa is Jaffa's not dissimilar to Garfield, except that Jaffa's 21 years old. And Jaffa's having a canine tooth extraction. I actually anesthetized this cat. I collected, or had them collect, the blood loss of this cat, and it was about 1/4 of a sponge. And we estimated it at 20 mils maximum. And what we see is that this cat's blood pressures dropped substantially. And in the essence of time, I was going to ask you, well, why is 20 mils of blood affected this cat so dramatically? And it's because he's 21 years old. He's a geriatric. And geriatric animals, their vasculature becomes stiffer, so it's less able to vasoconstrict and vasodilate, and their stroke volume becomes fixed. So the heart doesn't have the capacity to increase the stroke volume. So therefore, the cardiac output is volume dependent. If you take a little bit of volume away, the cat can't adjust its stroke volume, so the cardiac output's going to drop. And if the heart rate drops as well, these old animals, their cardiac output is also heart rate dependent because the stroke volume's fixed. So this animal is much more affected by a small amount of blood loss than Garfield, who took a substantial amount of blood loss. And so another reason to monitor blood pressure in animals, in old animals having dentistry, is that they're much more susceptible to sudden changes in blood pressure associated with blood loss. And on that note, I'm going to finish. And I'd like to thank Rachel for organising the event tonight. Outstanding, Rachel. I know there's a lot of work goes into these things. And Simon's been busily keeping track of the questions. Would you like to ask a couple of questions, Simon?
Colin, there's one on the board. I'll try and read it slowly. Question regarding post-induction apnea that comes right after induction. Causes and how to best troubleshoot.
Perfectly normal problem. Probably happens in 50% of animals we anesthetize. The cause of the problem is that we've given an induction anesthetic drug that's raised the respiratory set point of that animal. So the animal's not going to breathe until its CO2 hits that point that it wants to breathe. So the animals become apneic because you've given it a sudden dose of drugs that's raised or that has depressed its ventilatory center. So what we need to do is we need to make sure that animal doesn't become hypoxic in that period where the CO2 is rising. And we need to make sure that the animal takes some breaths so that it actually gets some inhalation anesthetic. So what we teach people is to give one breath every 30 seconds, a normal breath. In a dog, enough to raise the chest. In a cat, enough to raise the flank of the abdomen. Or if you've got a manometer in the breathing system, a 12 centimeter of water breath, and then let the animal alone for 30 seconds. If it doesn't breathe, give it another breath. If you give one breath every 30 seconds, it'll get some inhalation anesthetic, so it won't tend to wake up immediately, and the CO2 will rise and it should start to breathe in about 3 minutes.
Great, thanks, Colin. There's a lovely comment saying, I'm now both terrified and excited for my next anaesthesia case.
I just like to make a comment. Anaesthesia is anaesthesia is an active process. Anaesthesia is interesting, but it's about thinking. And what we've done tonight, I've given you a very compressed presentation and tried to give you some examples of things that happen during anaesthetics, not to every patient every day. But these are the things that we're thinking about when we're looking at a monitor. The monitor gives us some tools to help us. And what I've tried to show you tonight is how we use those tools. Anesthesia is fun, but it's an active process. So making a decision that this animal is at a good depth of anesthesia and I'm going to stand here because its parameters are fine and do nothing, that is a very good decision. Standing there doing nothing because I don't really have any idea what's going on, that's not such a good decision. So keep on going, Simon.
I think that there's one from Paul. Do you use glycopyrrolate at all?
Yes.
Was thinking about getting some for the rabbits and guinea pigs. Could we use it in dogs and cats instead of atropine?
Yes, glycopyrrolate, we use glycopyrrolate because it has a longer duration of action, doesn't tend to cause as much tachycardia. So if we've got a patient that we're worried about maybe raising its heart rate, we might lean towards glycopyrrolate. If we've got a patient where we want a longer duration of effect, we might use glycopyrrolate. The only downside of glycopyrrolate is if we pre-med the dog with glycopyrrolate and then it becomes bradycardic during the procedure, we're probably going to use glycopyrrolate instead of atropine to raise the heart rate. When we give a dose of atropine or glycopyrrolate to raise the heart rate in a bradycardic animal, the dose is roughly 1/3 of the sub-Q pre-med dose. So dose of atropine is 0.04 mg per kg. If we were going to give an IV dose, I'd draw up 0.04 mg per kg, and then I would give roughly 1/3 of that IV, wait 30 seconds to a couple of minutes for response. If the animal becomes more bradycardic, give another dose. Glycopyrrolate you use exactly the same way, except the dose is half the dose of atropine. But the disadvantage of the glycopyrrolate when you give it IV is it has a slower onset. So you're more likely to have an animal become a bit more bradycardic before the glycopyrrolate kicks in. Okay.
Thanks, Colin. Yeah, there's a couple of very nice comments. Thank you, everybody, for making those, but no more specific questions. So yeah, I think Rachel, that's
excellent.
Enough.
Yeah, that's lovely. Thanks, Simon. Yeah, lots of comments coming in, just saying how good that's been, and lots of thanks coming to you, Colin. So thank you very much to our audience. I think to say we've been online for only an hour and a half, I've learned a whole heap of stuff, and I would be equally terrified and excited if I was still doing anaesthesia. I think I'm quite grateful that I'm not, actually.
No, don't be terrified. Use knowledge, feel confident. So you've got some good information, be confident and go out and use that information. So next time you see things change on a monitor, you're going to be able to understand what's going on and you'll make better decisions. So the goal of the exercise is not to be terrified. The goal of the exercise is to learn and understand what the equipment's telling us. And one thing I'll say, Rachel, you can tell them, but I do believe that this has been recorded.
Yeah.
And so people can sit down and watch this again. I will tell you now that I could break this into 3 sections, this talk tonight, and I could spend an hour talking about blood pressure, an hour talking about end-tidal CO2, and an hour talking about pulse oximetry. So we've covered a lot of ground here tonight, and I would strongly commend you into taking a little time and maybe sit down and have another run through this, because there was a lot of information given to you. Okay.
There's loads of comments coming in, Colin, people saying how good it's been. Really appreciative audience. So massive thank you from me to Colin.
Put their hand up.
I think they've now asked a question in the Q&A or put a comment in.
Yeah.
Okay.
They're all
so thank you to our audience. To those of you who are still online, please just hang on for 10 seconds. When I finish the webinar, there will be a survey that comes up at the end. If you could leave some feedback, that would be hugely appreciated. We're taking just a short break over the summer from the webinar series, so they're normally every 2 months. Our next webinar is going to be in September. The other exciting thing that's happening in September is we're running a day of practical vet nurse training at VI headquarters in Sheffield. On the post-webinar survey, there is the option to tick a box if that's of interest to you, if you would like to receive some more information on that. So hang on, the survey will come up in just a second when I end the webinar. Colin, thanks ever so much. You can go and get your dinner now and get some sleep. I know Colin's actually quite jet lagged, so we really appreciate you giving your time this evening.
Thank you for your attention and attending tonight. We certainly appreciate it. All right.
Brilliant. Thanks, everyone. Have a lovely evening. Cheers, Colin. Bye.